The Maternity and Midwifery Forum brings you Matflix, video streaming from maternity experts. All your CPD and revalidation needs met in one place. Our expertly curated box sets are the perfect way to engage with the latest thinking, issue by issue. They make revalidation easy and are the perfect accompaniment to any project or university coursework. In addition to video from expert speakers across maternity and midwifery, there is easily accessible research and links to the latest government policy documents. Our reflective questions at the end are the perfect primer for your revalidation. In the same way the Maternity and Midwifery Forum provides certificates to show that you have attended these festivals, we can provide certificates for those who have consumed the content of a box set and submitted their written answers to the reflective questions provided by our curator, Dr. Jenny Hall. Midwives, maternity professionals and students, do not miss out. Subscribe to Matflix today. Box sets are just £17.50 each, or access to them all starts at £8.99 per month, and only £5.99 for Maternity and Midwifery Festival attendees. Students pay just £2.99 per month, and only £2.49 for Student Maternity and Midwifery Festival attendees. Check out the box sets at www.matflix.co.uk.
And good evening to everybody. Welcome to this week, which is session 8, series 3, and it's the Maternity and Midwifery Hour. So welcome everybody, and I'm really glad to see everybody. I can't see you, but I know you're there. My name's Sue Macdonald, and I'm the curator for the Maternity Hour and for the Midwifery and Maternity Festivals. I might mention those right at the end of the show. These sessions, as many of you will know, were designed in kind of response to the COVID pandemic, really as a way of getting some continuing professional development opportunities for midwives, for student midwives, for people who want to become midwives, also though for medics and for doulas, and I think we do have some mums who also tune in to see what we're up to. So welcome to everybody, and I hope you get something out of the hour. Thank you to Matflix, and these are the video streaming for midwifery experts, and they make sure that this will be recorded and you'll have access to this. You can tell your friends about it. Very good for revalidation, those midwives out there. Excellent if you've got a little assignment due, students, because there's loads and loads of information, loads of fantastic experts that we've had, especially over the Maternity and Midwifery Hour year. We've had some fab people, and we have 3 fab people tonight. We're going to be looking, and this is part 3 of a little series. We've been looking at haemoglobinopathies. And we're looking really today at some of the challenges and some of the complexities around the whole issue of supporting women and families with sickle cell and thalassemia. So I'm going to be joined by, you see, the wonderful speakers we have this evening. We have Joyce Adu Amankwah, specialist haemoglobinopathies midwife, and consultant haematologist Rachel Kess-Adu, and consultant haematologist Emma Draser. And we're going to start and put them all on the spot and ask them to provide us with a little moment of the week. So, Emma, how about you?
So my moment of the week was when I was out for a run yesterday, and it was still light, even though it was later in the day, and the blossom was coming through on the trees and the bulbs were coming out as well. And especially after the last year, it felt like spring was coming, and I felt a feeling of optimism about things.
It's a wonderful moment. Spring is my favourite time. That's wonderful. Thank you so much. How about Joyce? Have you got a moment? I know you've been on sort of holiday this week, Joyce.
Yes, I should be, but busy with other things and work as well. But finally, from tomorrow, I take time to rest and enjoy the days left. So that's what I'm looking forward for. And that's
Wonderful.
really contemplating. Thank you.
Thank you, Joyce. That's wonderful. And last is Rachel. Do you have a moment you can share with us, Rachel?
I do. And I know we're trying to get away from the pandemic, but I'm going to yank us back. So last week in our department, we had a session on the COVID vaccines, trying to encourage everyone to go and have it. And it's similar to this sort of session. You hold it, a virtual thing. You don't know what your audience is, what they're doing. And I've had 2 HCAs in our department come up to us yesterday who are both going to take the vaccine after that session. So I was very pleased.
Wow, fantastic. That's wonderful to hear. That's real influence, Rachel. Fantastic. Good news. Okay, well, thank you for that. We'll just do the usual slots now. I usually do a point at this point to just say we're still in lockdown, but of course, many of you will know that we're coming out of lockdown at some point with our roadmap. Now, this is also a good time for me to remind you that there are resources available as you go. And one of the resources is the roadmap document. I will warn you, it's about 40 pages, so don't print the whole thing out. But there are some quite snazzy little infographics, which are quite handy. I've printed the whole kind of summary, and it's on my fridge just so I can check what I'm allowed to do and what I'm not allowed to do. And what I will say is don't book a holiday yet. Not yet, just in case. Well, that's my superstitious bit of me. I won't organise one until I can really see that I can have a holiday. We actually need to say a big kind of tribute to some of the lost people, the people that we've lost ourselves and our friends, families, and to people who've died too soon. We can't forget that still the death toll is still there. And it's still very difficult to handle, knowing that so many people are dying and are still very unwell. And it's a good time to say thank you to the intensive care and high dependency care staff who are looking after very ill people at the moment and really putting their heart and soul, working over the odds. As our NHS, I'm always stunned by how fantastic our NHS is. We just rise to the challenge every time. So thank you to those staff for what they do to look after those people who are sick and their families and going over I won't say overboard, they're just going over the edge for everybody. And a big virtual hug and thanks to everyone in maternity care, because maternity services carry on no matter what. We can't stop elective births because they just carry on happening. So thank you to everyone who's working so hard there. And a big thank you now to all the people in the vaccinations centres, and Rachel's just described, you know, managing to feed those vaccination centres with people, and that's a big task which is carrying on, and amazing numbers are going through. Absolutely fantastic. And a great big thank you to all the key workers who are keeping everything going. And I say this every week, and I mean it every week, because we need all these services that keep the place going. And everyone from the postman to the milkman to the refuse collectors, everyone who keeps things going, everybody who just goes into work even when they'd rather not go to work. Anyway, right, on to this week's news. I haven't got a huge amount. I know it's the LGBT History Month, but there hasn't been a lot that I've been aware of, but you know, there's a link on the resources page. Vaccinations are well underway. We've hit over 18 million. We might have hit 19 million. I'm not sure if anyone knows the exact numbers today. I didn't hear the news because I was getting ready for this, but I know the numbers are going really well. And another good piece of news, I think, is that 600,000 vaccines of the Oxford vaccines have landed in Ghana today. And we know, I know it's a saying that we have, until everyone's safe, nobody's safe. And really it's so heartwarming to know that we are sending, things are going out all over the world. It's really important that we look after everyone that we can, as well as looking after ourselves. Also, the RCM has updated their COVID guidance, and there is a series of Q&As for pregnant women. That's been going on Twitter today. There was also an interesting paper, and again, this is on the resources page, from the Lancet on public health scheme, on the public health approach. And this is devising policy on infant feeding and mother-infant contact, i.e., separating mothers and babies does have a detrimental effect, which we kind of knew and we knew would be, but this is a very useful piece of research for you to have a look at. So check out the resources page. Okay, I did say a little earlier that this is the third in the series. We've been very lucky to have these 3 specialist colleagues come along to share their knowledge with us, focusing on haemoglobinopathies, really important area, and not it's not a simple area. You get some information from a textbook, but some of the things I know that Emma and Rachel and Joyce are going to talk about aren't always straightforward in the textbook, because guess what? Women and families are quite complex in themselves, and they may not just have one problem, and they also have a whole social makeup that we have to take account of. So we're going to be looking at this evening, and we're looking at the importance of this interdisciplinary work and teamwork and their communication. I think that'll come through very well from our 3 colleagues this evening. And we're going to start with Joyce, who is a special haemoglobinopathies midwife. She provides antenatal care for pregnant women with haemoglobinopathy disease and offers counselling, further screening for couples who are at risk of having a baby affected by major haemoglobinopathies, and she's been in practice for many years, so she's a very experienced midwife. And so welcome, Joyce. Thank you very much for coming, and I have to say the magical words of the screen is now yours.
Thank you. Okay. Give me, I've had this on and it's gone down. I don't know if you can see. Can you see everything? So we can start. Okay. Can you see that? Okay. All right. Okay.
Always some good technical issues for us.
I had already done this, but
I think you're getting our anticipation up there,
yeah.
Joyce.
Okay, share screen. Okay, it's open. All right. Okay. Yeah. Sorry about that. Is it the first time it's happened? You got it? Okay, I hope it's the right one I've got. Okay, I'll use this and go down with that. Thank you, everyone. Sorry about the technical problem, and it's always something to deal with. My name is Joyce, as you have been informed, specialist haemoglobinopathy midwife in St. George's Hospital. I go straight because we have had a couple of discussions before about haemoglobinopathies. Now, all pregnant women who have unusual hemoglobin are offered counseling and screening of the baby's father with consent. However, some fathers may not be available for testing. The reason being denial of being a carrier of unusual hemoglobin sometimes could be playing part of that. Also, work schedule or fear of the sight of the blood, needles, phobia, and some other reasons that may be relevant to them. So they may decline or may not be available for testing. On this slide here, I've put something there which I struggle a little bit to see at the moment, but I hope you can see. It's about picture about this invasive procedure that is offered. However, women need to know what is normal, from normal to what is unusual, so they can understand from the normal to the unusual, being able to understand their condition and help them in the decision-making process. So this is the picture of that. And actually, it's also, we offer the screening for every pregnant woman. This is including IVF pregnancy, as the last time we discussed in our presentation. And so it's offered between 11 weeks to 20 weeks. And amniocentesis offered between 15 to 20 weeks. It can be offered at a later date, depending upon the circumstances. However, if women decline to have the P&D, there is also a pathway of care for them, so that the babies are monitored for, to control mortality and morbidity. So they are offered, we discuss with them capillary testing and newborn screening at 5 days old. This is a story of patient A. She is a carrier, and her husband is, her baby's father is also a carrier. They had a child who died, who passed away on neonatal death at 3 months of age. So her second child was also affected, or is also affected with sickle cell anemia. Then she became pregnant with her third pregnancy. She decided then to go for pregnancy P&D, which is pre-diagnostic testing. Forgive me, this is not how I am. She decided to go for pre-diagnostic testing. But however, during the time that she'd been offered and the procedure to be started, she declined the procedure on the same day as she was about to take the P&D process, or CVS. And these are the following challenges that she was facing her and affecting her decision-making. In fact, in tears, she was complaining the labeling and the stigma and the rejection in her extended family. The fact that she has got a sickle cell child, she has felt lonely most of the time in taking the child to hospital, and it seems she wasn't getting any support. And the sister-in-laws sort of abusing her in some ways of the condition that she has, and has brought a sort of calamity upon the family. That is the word she has been using. In this case, it was very challenging for her to make a decision, either to go ahead with the process of the CVS or the P&D. The fear of miscarriage, which the CVS or procedure or amniocentesis procedure comes as a risk, is a very small risk. It's less than 1% in some cases, in some centers. But on average, the percentage of the risk of invasive procedure is about 1%. However, in some centers where this is carried out, the risk is less than 1%, which is about 0.7%. And so with this information, that's when it made her decide that she will go for the CVS to have the diagnosis. But however, she was afraid that she will have a miscarriage from that. She's also feared that she will have a child who is sickle cell, which means she's got one child who is a sickle cell disease, and she's going to have another child who is sickle cell disease. At this in the initial pregnancy time, and when we were looking for her for screening, we could not get through to her. And we thought that she had moved her house because she wasn't responding to her contacts, her mobile phones, not knowing that she was on admission in the same hospital with her child as 2 years of age. And so when we managed to get her, she was in tears again, crying to say that this is what she's facing. And that is what she's afraid to have again, another child who is also sickle cell. However, this is a one who has had a child who is complex. She has had a child who is died at 3 months of age, and it was because of sickle cell disease. She was also facing religious beliefs. The effect of it was that the religion that she's coming from, she's not allowed to terminate. However, in her and her experiences, she wished when she have that PND and baby is affected, she would terminate the pregnancy. And cultural religious beliefs as well. So these are the multiple of issues that was affecting her decision-making about the process or the PND. It wasn't just the PND, but because one, she has had a child who is affected by disease. Two, she's got a live child who is also affected by disease. And so she was contemplating and combining all this in the process. And it was quite challenging for her. The following is how we manage her. We gave her time and information to make decisions, and we respected every decision that she made. We had to respect her decision and go along with her. We had to involve multidisciplinary teams, the fetal medicine unit consultants, geneticists, neonatologists, and pediatric hematology team, specialist nurses in hematology were all involved in some way at every stage that the decision was made. Because when she was referred for PND, the consultant, fetal medicine unit consultants were involved. Genetics were involved for the counseling. Neonatologists were involved when the baby had capillary testing. The biomedical scientists were all sort of contact, not involved as a general, but contact in order to ensure a safe care for the baby. Because the main reason is to control morbidity, mortality, and morbidity. And that is the way we took her. And that approach is done with everyone that has a complex need and to make a complex decision. So the message to take home is that early referral, early screening for all pregnant women who are at risk is essential in the screening process. This includes IVF pregnancies. Screening the father of the baby is very, very important, and it's also to gain consent, because for them, they deny that they are carriers. It's very common with them. They also, because of their family, sometimes when they are going to have the test, they don't want their families to know because of the stigma and the rejection that they face in the family and in the culture. So it's not easy for this group of people or the people who experience haemoglobinopathy. As I mentioned the last time, when you have a disease, it's a problem. When you are a carrier, it's a problem, because families don't want families to marry anyone who is a carrier because of the risk that they are going to have a child who is affected with a haemoglobinopathy disease. And so this is the problem that is there, but with respect, care, and support, they can make decisions about their pregnancy. So it's important to discuss options earlier at onset and possible outcomes and offer the PND. And it's important to be aware of the challenges and dilemmas they face, the fear, the stigma, the labeling, the cultural and religious beliefs. With adequate information, support, understanding, respecting their decision-making, they are able to make choices that are suitable for them and their families. Thank you. And I do apologize for the sliding. Thank you.
Now there's me saying no problem, Joyce. Now it was muted.
Okay.
Thank you so much. And I mean, it's I think you've highlighted the difficulty for many of these women and their families and their wider family group. And it sort of, it hits me what a terrible decision that would have to be made. It's kind of a no-win situation in a lot of ways. So thank you very much for setting out the context so well. Now, can I just remind our audience, anyone who wants to ask a question, get the questions in now, because we do have time at the end of the programme for questions to be answered by our lovely speakers. So thank you very much, Joyce. Well, I'm not sure if I meant to just introduce Rachel or Emma together. So I'll introduce Rachel, who is qualified from Imperial College of School Medicine in London and specialised in haematology at King's College. She was appointed to her current consultant haematology role at Guy's and St Thomas's in 2012, and her research interests focus on the cardiovascular and neurological complications of sickle cell anemia. She's one of the network leads for the South Thames Sickle Cell and Thalassemia Network, chair of the guideline writing group, and clinical lead for the Haemoglobinopathies service. This is a real juggle over the wording. So Rachel, the screen is yours.
Thank you so much. So I was hoping to have a bit of a conversation with Emma. So it'd probably be a good idea to introduce her as well, as I'm sure she'll have a few words to share.
Then I shall too. I'm delighted to introduce Emma, who's with us again. She's a haematology consultant at the Whittington Hospitals and University College Hospitals. Her PhD was based on research into markers of severity and predictors of organ dysfunction in sickle cell disease. She's North Central London and East Anglia HCC lead for sickle cell, and the North Central West London and East Anglia HCC lead for thalassemia and rare anemias. And her specialist interests are sickle cell disease and thalassemia and hemochromatosis. So welcome, Emma and Rachel. So we have a lovely double act, and then we're going to have a triple act at some point. So welcome. The screen is yours.
Excellent.
Both of you.
Thank you very much. Following on from what Joyce has just shared, I thought it'd be useful to share a real life example of a woman going through this sort of situation. So I'm going to give you a history of one of our ladies who I can start off by bookending to say she's very happily had a healthy daughter and who's about 1 year old actually at the moment. So all's well that ended well. But her story began, she got married to a British Nigerian chap about 6 years ago. She lived in Nigeria at the time. And because Nigeria has the highest concentration of sickle patients, it is not an unusual thing that people verbalize to each other, do you have sickle, or is there sickle in your family when you're getting married? So they'd had this conversation and neither of them had any immediate family members with sickle. Now she knew she had sickle trait, which is what she told her husband to be. So they got married, moved to the UK, settled down. A couple of years in, she gets pregnant with her first baby, and as per standard screening antenatally here, she discovers to her surprise she doesn't have sickle trait, she has sickle cell disease. What she has is the SC type of sickle. So she had been told at screening in Nigeria that she had sickle trait, but it's not uncommon that we have people who think they have trait arrive here and get screened and find out actually they have condition, just mild condition. So suddenly this throws a spanner in the works. So first of all, her partner has to be screened, which means she obviously has to go home and tell him what she's discovered. I mean, she should do that anyway, but she has to because he has to be screened. It did not go down well at all. He was convinced she had deceived him, that she knew she had sickle and just hadn't told him. They had a fairly horrific few weeks. Anyway, eventually he agrees to be tested, although as far as he's concerned, he has no family history of sickle. He's HbAA, so this is all just semantics. He has his testing and he has sickle trait. So suddenly they're faced with another conundrum. Now, do you want to get the baby screened? Obviously, time is moving on while all of this is happening. So she's coming up to, I think, 16, 18 weeks at this point, and they're having the conversations about, do you want to test to find out what your baby's going to have? Because he is absolutely adamant he doesn't want to have a sickle baby. She's already distressed about this whole, she's got a new diagnosis. She's trying to convince her partner that actually, I didn't know, I'm finding out the same time as you. So she's dealing with all of that and then having to make decisions about whether she wants to find out what her baby's condition is and what is she going to do with that information. It was a fairly horrific few weeks. And then unfortunately for her, when she got to about 22 weeks, decisions are made, lots and lots of arguments, she miscarried. Which I think it was all a bit horrific, and she needed a lot of counseling afterwards, because I think part of her feared that she had willed the miscarriage to happen. It was quite horrific. Anyway, so fast forward a year, and they together, marriage is fairly healed with some simmering emotions underneath, one would imagine, but they're making decisions about the next baby. So the husband's absolutely adamant they're going to have PIGD, which is pre-implantation genetic diagnosis. It's essentially IVF with selected embryos. So they don't have a child with condition. So we refer them for this, they're entitled to it, they're going through the workup for it, and she falls pregnant without PIGD. So the question comes up again, what are you going to do? Are we going to screen this baby? Do you want to test it to find out what the status of the baby is? Do you want to just carry it through and then find out at the end? There's a bunch of options you go through. At this point, she's now had a couple of years, I think about 18 months, almost 2 years, to come to terms with her sickle diagnosis. She's fine with her sickle diagnosis. She envisages she's going to be fine having a child with sickle. Her husband doesn't want to have a child with sickle. So she then goes through the rest of her pregnancy with her husband, being quite clear that he doesn't want to have a sickle baby. So if they have a sickle baby, they're going to give it up for adoption. Oh. She just keeps nodding along, going, okay. But then telling her clinical team, now I'm keeping this baby, come what come may. It was fairly horror. It was fairly horror. Anyway, at the end of it, they had an AS baby. She's home, baby's fine, all is well. But that's an example of the sort of complexity these women can sometimes go through, because of course the difficulty for her, as Joyce will well know, is it's not simply just dealing with her husband, because African marriages are not simply just a husband and a wife, it's two families. So there's a lot of recrimination that goes back to her family. There's a lot of recrimination she faces from his family, and his family's here, hers is back in Nigeria. It was fairly awful. And Emma and I trained together, and we had a similar situation where someone who didn't know they were trade had a husband who obviously was straight as well. He also didn't know he was straight. So neither has family history of sickle. And then she gets pregnant, finds out she's straight, but they're not that bothered because he's not going to be straight. He doesn't want to be tested for whatever reasons. I can't quite remember. Probably measles phobia is probably the most common one. They have a baby who has sickle, and he walked out on her. Do you remember? We were renters when that happened.
Yeah. He left her, and the fact, and but then the other thing can happen, because I remember another patient who we both looked after, who was in a relationship with a chap, getting serious, thinking about starting a family, and I remember her bringing him to clinic, him getting tested, them coming back to get the results. He was straight. This was one of our patients who had sickle cell disease, and she dumped him in the room.
Yes, she did.
Dumped him in the room in front of us.
Yes, I remember that.
And it was, but she had severe sickle cell. She knew, and she was very clear with him before he was tested that if he had traits, that was game over, and she was always very clear about the fact that, sickle cell had a massive impact on her life, in a really negative way. She spent months and months in hospital. She was quite small, she hadn't grown properly, you know, had again very complex family situation due to stigma in the family around her diagnosis, from her first degree relatives, from her mum, from her siblings, and she didn't want that for her child. That was her decision. Yeah. And I think it's interesting because your lady, Rachel, had obviously quite mild disease because she didn't know she had sickle at all. So
she didn't, which is why for her, the thought of having a child with sickle cell, well, she just thought, if sickle cell can be my experience, why can't I have a child with sickle? Although she was made aware that the experience is across a breadth and you can't predict even with the same genotype. It is, I mean, pregnancy in sickle is, apart from the actual managing the pregnancy itself, the complexities of genetic counseling, the complexities of, you know, what do you do with the results? A lot of sickle mothers are highly religious as well. So as Joyce pointed out, even talking them through, do you want to go through PND? Do you want to have the diagnosis? That has a risk of miscarriage. And for some people, that's unacceptable. For some people, they will go through the PND to find out what their baby status is, but they're not going to terminate. It is not, it's not even a factor for them. But for the partner, it might be, well, in that case, I'm walking. You know, it sometimes can be so awful and difficult.
Because in thalassemia, it's slightly more straightforward in a way, because our patients are either transfusion dependent or they're not transfusion dependent. And that's mainly based around the change in the gene that comes from the mum and dad. And the case I was going to say was of a lady who actually doesn't have thalassemia. I first met her because she's the sister of one of my patients who does have transfusion dependent thalassemia. And this boy is one of my more complicated patients. He's had variable compliance with his medications over the years, i.e. not much, and actually has ended up, you know, twice in the relatively short time that I've been a consultant, 5 years, with very, very severe iron loading in the heart. And if you remember the last talk, that's one of the things that happens if obviously people are transfused regularly. They build up their iron levels if they don't take their chelation medicine. You know, this chap's, you know, he's a very charming boy, but he's never really taken his medications. And he actually had a very severe level of iron in the heart, the highest level of iron in the heart that has been seen at either of my centres in the last 10 years. But his sister was brilliant. You know, she would, you know, when he didn't turn up for things, we'd phone her and she'd drag him along, and, you know, has been really important in getting him to comply. And actually his compliance has been a lot better recently, and this is possibly why. So she had thalassemia trait. Her husband had thalassemia trait. They both knew about that before they got married. It was an arranged marriage, and they're both practicing Muslims, but they have always been very practical about thalassemia. They had 2 children and had prenatal diagnosis for both pregnancies. They didn't have pre-implantation genetic diagnosis, and both those children were thalassemia trait. For the 3rd pregnancy, they were trying to save up because they've got 2 healthy children. They don't qualify for pre-implantation genetic diagnosis under the NHS, and so they were saving up to have PIGD. But surprise, they fell pregnant before that could be arranged. And so she decided she's going to have pre-implantation, you know, her PGD like she had done for the previous 2 pregnancies. But this time the child was affected and did have a high likelihood of having transfusion-dependent thalassemia. So this girl has seen what it's been like with her brother, seen him having to come to hospital twice every 3 weeks, seen the impact on his health of him taking and not taking his medications, and also the effect that's had on her, with us randomly phoning her up and saying, he hasn't turned up again, where is he, trying to help her to hunt him down. So she was conflicted about it. She's got 2 children with trait, but we wanted to help her to make an informed decision. Okay. So what we ended up doing, and her husband was, I have to say, extremely supportive, as was what was nice was the whole family was supportive of her, including my patient. And so we introduced her to one of our specialist nurses who looks after the children, who went through, took a lot of time with her, went through what current management of children with thalassemia are, because her brother's in his 30s now. Things have changed and things have definitely improved. We introduced her to another mum, just put them in phone contact, so that she could talk to someone who has the child with thalassemia, in a peer support way, and also put her in touch with the UK Thalassemia Society to so she could have like a rounded, informed decision about what she wanted to do. And in the end, decided to keep the baby. We did go through discussion around termination. It was early on because she'd presented early, Joyce, to her testing, because she was aware.
Important. It's very important.
She was on it. So even though she was a practicing Muslim, it was still early enough where she could have terminated the pregnancy and been consistent with her belief system. But it was interesting, and I spoke to her because I knew her well. My other specialist, the adult specialist nurse, spoke to her, and and baby's doing very well, not such a baby now, must be 2, and is, doing very well with transfusion, and will probably start, if not hasn't started collation yet, will do in the next few months. And, hopefully, potentially will have the benefit of curative therapy. If one of its siblings is a bone marrow match, then could have a curative transplant, or potentially in the future other therapy treatments like gene therapy, etc. But it was a different case, but still sort of some complex issues.
It is. I mean, I think living in a family where you have a sibling who has an inherited condition, there's so many complexities to those homes that people parent differently when your child has an inherited condition, because there's a sense of blame within the parents about it. And then the stigma, when it comes to sickle, stigma is a huge thing. How much is stigma an issue in the Thal communities?
So it's different. So I think historically with the my older Cypriot patients, they were put in, because they were expected to die. So they didn't really even get options for education. They were put in like special schools, and no one really they didn't really have the same opportunities. Then I think, particularly in Cyprus, they passed a law where everyone had to know their thalassemia status before they could get married. So you went to the priest without your thalassemia status, you weren't getting married, and that had a massive impact on thalassemia births in Cyprus, like massive. Population's changed now. My younger patients and this family are from the Indian subcontinent, and then I think there is definitely a stigma, especially with arranged marriages. It's bad blood. You're going to have a sick child. You're not healthy. Especially depending on how well they've been transfused or collated previously, the the patients can be small, they may need help to go through puberty or have to have, you know, fertility treatment, boys and girls, this impacts on, and the stigma affects the guys as much as the girls in thalassemia. And yeah, so it can be quite difficult. And I know, yeah, I've had a lot of conversations with patients about, you know, going into an arranged marriage and their parents saying, you know, you shouldn't tell them about your status, but they need to, because it's like a massive part of their lives. And I always say to my sickle and my thalassemia patients, you're starting a new relationship, you bring that boy or girl, you know, man or woman, to the clinic. You know, they need to be judged by like the clinic aunties to you know, I was like, you think your family are bad, you know nothing of badness till, because I think it's important, it's a massive part of their lives. They need to understand it, that it's part of that person. It's not a bad part, it's just part of them. And if they don't appreciate it and understand it and care about it, they're not going to be a good partner.
That's true. Thank you. I think that we could probably stop there.
Wow.
Soon.
Yes, I think this has been really interesting, because I think it's given a feel of a quite a long-term arrangement with the clinic aunties, which is and a sort of kind of the stories I think are really make that come alive, especially, you know, when a partner or a prospective partner then dumps that other partner in the clinic. I mean, that's a very vivid kind of end to the story, isn't it, really? And the honesty issue is really obviously really important. So thank you for all of you for putting all that out. We do have some questions, which is why my eyes keep going this way, because it comes on my other screen. And I have I can throw this to all three of you. I've got, first of all, Susan Vining is saying, could I ask Joyce, what are the cultural beliefs that affected patient A or can affect other patients in general?
Okay, so she's of, as Rachel was making that in her statement, that some from Nigeria is high in sickle cell, HAB, HSS. This is also from Ghana. And it's very common with Ghana, Nigeria. I didn't want to mention countries, but here we are. I think it's become open and we have to be aware of this because we will face them. There is a taboo in some, not all cultures in Nigeria, but some cultures in Nigeria is the stigma that you don't have, sickle cell will die, so we don't need to marry them. Ghana also has this problem in terms of when somebody is a sickle cell disease, if it is not the SS, which is being diagnosed and treated, sometimes they underestimate it or underdiagnose it and say that there's a term called ahonam-tutu, means that it's just you got pain in your body, but it's not considered as sickle cell. In our clinic, we have had 2 from Ghana who are sickle cell disease, and that they have been, the type is SC. So I was going to raise this up at some point, is that when we are doing the screening, it's very, very important that even if the man has been screened outside UK somewhere, they will claim that they have been screened. It's very important to have them screened again, because some countries are not able to identify these other genotypes, like the E, C, and the Ds, but they are all contribute to the sickle cell disease if they come in contact with the S genotype. So it's very, very important. So when I say the stigma, it's actually related to the fact that they are sick all the time. They can die shortly. I had a lady in our clinic. She's from Jamaica, and she said she will not let her husband be tested, and she's had a disease. She'll not let her husband be tested because when everybody knows that the baby is at, the husband is also a carrier, the tendency everybody is going to reject her. So rejection is the most, of stigma in the community.
Yeah,
and in the family as well.
And I think you focusing on, I mean, culture is quite a broad thing, because
it was something like the last teaching I was doing about the screening. There was hereditary persistent fetal hemoglobin. I mean, I can't pronounce it more. However, this was diagnosed among an Irish. Now, this lady, when she was diagnosed, was identified that she's a carrier, she got the courage and confronted her dad to ask about if he has known anything about it. And the dad said yes. He knows that some of the family, there were two of the family that were sick all the time, but he didn't want to mention to anyone. So it may sound that it's only in African country or cultures, but it's everywhere. And I want to raise the point that haemoglobinopathy condition itself is underplayed. The stigma is everywhere, and everybody, try to keep it. But it's a disease that you can't keep it. Here is a case that their survivor is very, very important.
Yeah, and we need to know our history, our family history. I know there was some research a wee while back about that, so that's grand. Thank you very much, Joyce. I've had a question from Samantha Firth, who wants to say, can high-risk couples, especially those utilising IVF anyway, access PIGD?
Yes.
Yes.
So as long as you don't, the NHS will pay if you don't have an affected child. Yeah? Yes, if you have a child who has condition, or you don't have any children, then they'll pay for it. But if you have a child without condition, and that's the mother has a child without condition, then you have to pay for it. But you can certainly access it.
That's interesting. Thank you for that. That's grand. Okay. And then I've got a question from Mary, who says, thank you, Joyce. You as a midwife, if you could get 3 things across to undergrad students read this topic, what would they be? This could probably go to Emma and Rachel as well, but I'll ask Joyce first.
Thank you. I would suggest that update your knowledge, because as a midwife, you never go away with the condition. You will definitely come across when you are doing the antenatal booking. Your knowledge is very, very important when you are doing the antenatal screening. It's also important when you're providing care for them in pregnancy. You may be not specialists, but however, when they come to labor ward, they need care. When they go to postnatal ward, they need care. When everything, they may have specialist care in the antenatal period. However, labor, postnatal, all midwives provide all care, and they will come to you. So it's very important to abreast ourselves and educate ourselves in this area so that we can provide them with care. Also, empathize with them. I would say there's this stigma all the time about sickle cell and thalassemia, and that actually hurts my heart, because I don't want to give them too much opportunity. Sometimes I know where they are, and then some have been in hospital for a long time and they know what they want. However, you have to understand where they are coming from and offer them the support they need. Sometimes they may be asking for pain relief, or when it's on admission with the disease, they may be asking for pain relief, and you may not understand the reason why they keep asking for the pain relief. Their pain will not seen, but they feel it. And so it's important to listen to them. I think that's what I'll say for now.
I think that's a brilliant one to finish with, actually, Joyce, the listening to them, because the pain issue has long time been an issue, hasn't it? So thank you very much for that. Okay, we've got another question from Mavis M. A recently launched SCD and thalassemia guidelines launch. Heard some genetic centres in low risk areas say they're not knowledgeable in SCD. Does this not perpetuate inequalities? Patients can't get PGD advice. How do you empower people to get this care? Well, any volunteers for this one?
Yes. I think I leave it to the two to talk.
I wonder if that's bits around the basically all the genetic diagnosis centres have now been centralised. So the government have now centralised the centres to provide the testing. So this is meant to improve the quality of the genetic testing and standardise it a bit more. But as you say, the problem is that then if you if you're not getting that information with the conversations, that initial conversation with someone who knows what they're talking about, then that is going to be have health inequalities. So so NHS England have tried to address this by creating the specialist haemoglobinopathy teams and also the haemoglobinopathy coordinating centres, who should provide support in this situation. So like Joyce and I are in the same HCC for thalassemia, but we've got our own HCCs for sickle cell, and Rachel's also in a different HCC. And so for thalassemia, my network, as I say, goes out from East Anglia across to Bristol, down and into Cornwall. So there's a lot of low prevalence areas there. Yeah. And I think it is about the clinicians and empowering the clinicians to seek early advice. That, you know, there's no shame in asking for advice. I'm always happy to, you know, be asked a question. You know, sometimes we get emails or queries from Scotland, you know, other low prevalence areas. And I think it's really just to say to all the trainees and midwives and anyone else on the call, there's no such thing as a stupid question. You know, if you don't know, you ask, because these are people's lives, and it's always better to check. You know, I ask questions all the time.
I think for here, I would say that it's important to get information. You can check on the web, the haemoglobinopathy coordinating centers. There is 10 for sickle cell and there's 4 for thalassemia. And so when you type in haemoglobinopathy commissioning centers, you will get the areas and locate which is nearer to you or which one you can access and refer for advice. We do get some pediatricians or some consultants from different hospitals, nurses from different hospitals asking and referring for advice and a brief understanding of the case they have at hand. So it's important to do that in order that you provide the care that the patient needs. Thank you.
Fabulous. No, that's a fantastic answer. Thank you very much for that. I've got another question from Layla Saad, who says, in midwifery or general, she's expanding it a bit. Well done, Layla. How prevalent is sickle cell and thalassemia in families that are related compared to those that are unrelated? I'm thinking that must mean first cousins or whatever.
Yeah.
Yeah. So in thalassemia, you would see an increase if it's first cousin marriage, then there's theoretically an increased risk, because you're more likely to have 2 people with traits who will have an affected child. However, in certain populations, you know, historically Cyprus and in the Indian subcontinent, it's exceedingly prevalent. You know, these are changes in the gene that have persisted because of a population, they give a population resistance to malaria. You know, that's a massive sort of evolutionary drive at population level for these changes in the gene to persist. And so it's, you know, I'd say if you're in a prevalent population, first cousin or not first cousin, you know, you still need to be screened.
I suppose the only thing with if you're first cousins, you probably know the history, and you might know if you've got someone's got a trait, of course. It's another issue. I think the final question, because we've had some fantastic questions, thank you so much to everyone, from Sharon Tunnicliffe, Is there any ongoing long-term psychological well-being support for these families? Really good question, Sharon. Because
I like that question.
yeah, I thought you might, because I think you've
that question
demonstrated what is needed by families.
Exactly. That is what is needed. Something that is missing. You have someone who has had 2 terminations because the baby is affected. You have another one who has had 1 termination, 1 is affected, and had depression after. So what pathway, which is very, and to us, is very important for us to look after their mental health. And so there is, I don't know about different centers. However, in our place, there is a maternity counselor, and these women are referred to them for follow-ups. And I believe and I wish that many centers will follow suit if there isn't, because they suffer a lot. There is one point I did, and I removed it because it wasn't relevant in this woman's case, because she did not experience depression in this process. But there are a couple of them, or some of them do experience depression. And it's very important to have that follow-up care, the postnatal care. That's postnatal care for their mental health and for their desire to continue or come back for another pregnancy. Because some people, it put them off of having another child who is affected. I'll go on. There was a question on my mind that I wanted to have. The PGD. Emma, you mentioned, if I'm right with that, it's not easy referred, is it? It's not easy accessible.
Pre-implantation genetic diagnosis.
Pre-implantation.
Yeah. So, yeah, it's not. I think this is something that it does a bit depend where you are. I don't know. Rachel, do you have a view? Problem is, it's not an easy process either.
We have it, so
yeah, we have it.
Straightforward, yeah.
And my thing is though, PGD. We'll have pre-implantation genetic diagnosis, but we'll be fine. But actually, it's an IVF procedure, so the woman has to, have all the hormones, etc., etc. Husband has to have loads of testing as well. Then, the embryos, if there are any, are then tested, and then, if they are, if there are no unaffected embryos, then that cycle's, done and dusted. So it's a very difficult, it's not an easy procedure. Some of my ladies have had 3 or 4 cycles and still haven't had a successful pregnancy as yet, which is, psychologically, back to the question, is a massive burden. We also have specific psychologists attached to the haematology service, Haemoglobinopathy service, who provide support for all our patients for at different stages. So,
it is worth mentioning that the women who have condition will have appropriate psychology support if they are followed up by even a local sickle center. But certainly, if you have access to a specialist center, you will have a psychologist. I guess the main issue here is if you're a mum with trade, then you're dependent on what the women's services has to offer, and that's a bit more problematic.
Yeah.
I could listen to you 3 for a lot longer, but our time has raced ahead, as it always does. So I want to say a huge, huge thank you to Joyce, to Emma, and to Rachel for really opening out just a touch of the complexities. This is this is typical women and juggling, because these women are juggling with these issues every day and doing brilliantly and supporting women and their families so brilliantly. So thank you to them for sharing some of that with us this evening. And thank you to everyone who's asked fantastic questions and have come tonight to listen in. We'll be here next week for another Maternity and Midwifery Hour. And in the meantime, in this time between now and then, take care of yourselves, and we'll look forward to seeing you soon.
Thank you.
The Maternity and Midwifery Forum brings you Matflix, video streaming from maternity experts. All your CPD and revalidation needs met in one place. Our expertly curated box sets are the perfect way to engage with the latest thinking, issue by issue. They make revalidation easy and are the perfect accompaniment to any project or university coursework. In addition to video from expert speakers across maternity and midwifery, there is easily accessible research and links to the latest government policy documents. Our reflective questions at the end are the perfect primer for your revalidation. In the same way the Maternity and Midwifery Forum provides certificates to show that you have attended these festivals, we can provide certificates for those who have consumed the content of a box set and submitted their written answers to the reflective questions provided by our curator, Dr. Jenny Hall. Midwives, maternity professionals and students, do not miss out. Subscribe to Matflix today. Box sets are just £17.50 each, or access to them all starts at £8.99 per month, and only £5.99 for Maternity and Midwifery Festival attendees. Students pay just £2.99 per month, and only £2.49 for Student Maternity and Midwifery Festival attendees. Check out the box sets at www.